Hi, everybody. Can you hear me? Great. Welcome to our April 26 office hours. I'm Joanna Katzman. I'm a neurologist at Project ECHO and UNM. And it's great to see everybody on video. And if you have a webcam and you'd like to turn that on, that would be great. For many of you, it's your lunch hour, and it's perfectly fine to eat and drink while you're on video and with us today. I'd like to introduce my colleague briefly, Dr. Carla Thornton.
Hi, good morning. Good afternoon, everyone. Carla Thornton, infectious diseases physician and associate director here at Project ECHO.
Thank you. Thank you, Carla. Hope everyone is doing well and staying safe. I'd like to introduce Nestor Sosa, our leader here. He's the Division Chief of Infectious Disease at UNM School of Medicine. Nestor, I think we'll begin with you with your presentation. Thank you, Nestor.
Thank you, Joanna and Carla, and thank you for always being such good moderators. I think I have never thanked you before, but and to all the participants for being here week in and week out every single week. So let me just try to share my screen and go directly to the update. All right, good. So we'll I have several papers to share, but first of all, I want to just share with everybody the fact that the Johnson & Johnson pause was lifted, so people will be able to vaccinate. And this is the language the CDC and the FDA posted in the webpage in case you haven't seen it. They said use of the Janssen COVID-19 vaccine should be resumed in the United States. FDA and CDC have confidence that this vaccine is safe and effective in preventing COVID, and the FDA has determined that the available data show that the vaccine known and potential benefits outweighs the risk, basically in 18 years of older. So they did not put any restrictions, like they didn't limit it to only males or over 50, like in other countries. They actually open it to everybody over the age of 18 years. I sort of heard the press conference that Dr. Walensky, the CDC director, and other dignitary from FDA did that day, and I was able to get some of the information and also available in the webpage. So first of all, they added a few cases, so that we have so far a total of 15 cases of this thrombotic thrombocytopenia syndrome associated with the vaccine. Before, if you remember, I presented the data on 6 cases, so it's a total of 15, and that's what they were waiting for. They were basically analyzing those who had recently been vaccinated to make sure, and they found that, in fact, all of these cases occur in women, so no cases in male, and 18 to 59. So they brought them a little bit. It was 18 to 49, if you remember. So there was a couple of cases in older than 50. And then the same issue presentation between 6 and 15 days after vaccination. That was sort of the summary of the update of the new cases. And they actually did a risk-benefit analysis, and they said, well, the incidence of this event in 18 to 49 is 7 cases per million. And for women over 50, only 0.9 cases per million. And they compare that with the risk of COVID and death and COVID hospitalization in the same age group. So if you're 18 and 49 and you're vaccinated, you can avert 650 hospitalization per million and 12 deaths per million. And if you're over 50, 4,700 hospitalizations are prevented and 600 deaths are prevented. So when they look at these numbers and this number, they say, well, the benefits definitely outweigh the risks. And that's how they reach that conclusion to open the vaccination again with J&J. The second topic that I want to go over, and I apologize, this is a very sort of complicated paper, so you have to be. I actually read it like two times and spend a lot of time with the graph. So I'm going to try to go over. It was analyzing using the VA database. They actually published what they call a high-dimensional characterization of the post-acute sequelae of COVID-19. And the way they did it, this investigator, I think they were from the University of Washington, they actually took 73,000 veterans who had COVID during the pandemic in the US, and they compare with 4.9, almost 5 million veterans who did not have COVID. This is like the powerful database that the VA, Veterans Health Administration, has available. And they selected patients who had survived beyond 30 days and that were not hospitalized. So these are essentially patients and controls that were not hospitalized during this period, that just, and for the COVID patient who had COVID as outpatients or were managed and as an outpatient, and they look at what happened to them after they had COVID. And the main sort of the headline of the paper is that even if you had COVID, but you didn't go into the hospital, you have a hazard ratio of death of 1.59, meaning 60% more risk of death or 59% higher risk of death if you had COVID than if you did not. And they compare this to the regular VA patients with other diseases. And in fact, there was an excess death in this group of COVID survivors of 8 deaths per 1,000 patients during the 6 months of follow-up. So definitely COVID, even if you didn't die of COVID during your initial infection, it impairs somehow your health. And then they went ahead and analyzed the excess of diagnosis, new diagnosis or incident diagnosis, the excess use of medication by these COVID survivors, and even the abnormalities in the lab. And I don't expect you to read this graph just to have an idea. These were the number of diagnoses that were sort of new or added, and they were in excess compared with the cohort that didn't have COVID. So obviously respiratory symptom, 28 per 1,000 excess diagnosis, hypertension, and you can go down the list. Basically all systems were affected by this post-COVID disease or post-COVID syndrome, if you want to call it. So there was a lot of new diagnosis on this patient after they had COVID in the VA system. And if you look at medication use, there was also an excess use of medication. And you can see these are all the numbers are excess consults or excess prescriptions for per 1,000 subjects compared to the controls. So basically bronchodilators, analgesic, anticoagulants, non-steroidal, etc., were used by these 73,000 patients. And even laboratory abnormality was much more common in COVID patients, things like low hemoglobin, increasing A1C that we have seen an association with diabetes decompensation, etc. So a lot of medication, new diagnosis, and laboratory abnormalities in this cohort of 73,000 veterans who had COVID versus those who did not, who were just users of the system. And these were, again, non-hospitalized COVID patients. So amazingly, an amazing use of healthcare resources by this population at the VA. And then they did, I don't expect you to understand this graph. It took me like 30 minutes. I'm still not sure I understand it. But they basically tried to put the whole thing in a graph. And they said on the outsides are the hazard ratio of the post-COVID syndrome. And those in yellow are those hazard ratios which are over 1. So there were a lot of diagnoses that were more common in the post-COVID syndrome in these different organ systems, ear, endocrine, circulatory. And you can see the darker color in this inner ring means the excess burden of disease among the COVID patients. And finally, the P's, those who are statistically significant, they graph the P, the negative log value of the P. So the longer the bar, the more zeros have the P. So more significant the difference between the past patients and the control patients. So it's an interesting way to present the data, but what this means basically is that the disease burden and use of the healthcare was significantly higher among those who were considered COVID survivors than the controls. And the fact, another aspect of this paper, they also look at patients who were hospitalized in orange or in ICU. So there was sort of a broader a cohort of patients, and they compare the chances of having post-COVID syndrome and the severity. And there was obviously a correlation. The hazard ratio of having post-COVID syndrome was higher in all the categories in those who were in the ICU, followed by those who were hospitalized. And even those who were not hospitalized obviously had more events than the control group. So although obviously ICU and hospitalized patient had a lot of issues post COVID, even those who were not hospitalized had more events than those who had another diagnosis. And there was obviously this correlation between COVID severity and past severity in these analyses. Okay, so much for post-COVID. So the conclusion, just to summarize, 60% increased risk of death after COVID without hospitalization, a broad array of incident pulmonary and extrapulmonary manifestations, increased risk of incident use of several medications, especially opioids, antidepressant, etc. And finally, a correlation between severity of the disease of the acute COVID and the post-COVID sequelae. There was also a publication on the use of mRNA vaccines, and I think we reviewed this in the pre-publication, but now it made it to the New England Journal. So these authors from the CDC actually published the data on almost 36,000 pregnant subjects who receive either Moderna or Pfizer vaccine here in the United States. And you can see the distribution by age. Most of them were pregnant when they were vaccinated. 85.8 and 87.4 were already vaccinated, and some of them became pregnant shortly after vaccination. And the important finding on one side is that adverse event, the reactogenicity was not worse. In fact, the light blue are the pregnant, and you can see that most of the bars are higher in the non-pregnant than in the pregnant female, except for pain. So pain in the site of injection was slightly more frequent in pregnancy, but then the rest of the symptoms, systemic, fatigue, headache, etc., were less common in pregnant subjects. So that was sort of reassuring. And the other, probably most important finding are the frequency of pregnancy loss and neonatal outcomes in these subjects. And this is from the Be Safe Pregnancy Registry. You can see that the percentage here in parentheses of these events, spontaneous abortion, stillbirth, preterm, small size for gestational age, etc., are very similar to what is reported in the literature. And the author give this the published incidence of these events versus what happened in this group, and there was basically no safety signal, and that was the main conclusion of this paper in these 35,000 subjects that were analyzed in the Moderna and Pfizer vaccine registry here in the US. Something that we have been listening to are the vaccine breakthrough infections, real vaccine breakthrough infections. And in fact, there was a report in the New England Journal of 2 cases. And this is interesting because they just reported, and this made it to the New England, but two well-documented cases. One was a 51-year-old female that developed COVID, symptomatic COVID, 19 days after the second dose. So she was fully vaccinated with Moderna. And another case of a 65-year-old that developed symptomatic COVID 36 days after the second dose of the Pfizer vaccine. And the interesting aspect of this paper is that they actually did a full genome sequencing of the patient number 1. Hold on a second, let me mute myself. That is taking my concentration. So let's see what they found. First of all, the patient number 1, they were able to obtain antibodies early in the disease in this symptomatic COVID, and she had very, very, very high levels of neutralizing antibody, and they're comparing here neutralizing antibodies of those vaccinated, the population, those who had not natural disease, and you can see clearly that this patient was sort of on the high side of the levels of antibodies. So it was not that she didn't mount an immune response. She had an immune response, but nevertheless developed symptomatic COVID. And that's one of the findings of the study, that even if you have appropriate antibodies, you can develop COVID despite being adequately vaccinated. And then when they look at the mutation, they did find several significant mutations. They found the E484, which is one that had been associated with ImmuneScape, and many others. You can see this one detected. So they actually map out all the mutation that she had. So she did have sort of a special variant, a different virus from the original wild type virus. And actually, when they tried to put it this is a phylogenetic tree with all the clades and the variants, they couldn't really place this patient in any clade. She was between the UK variant and the New York variant, which is called 526. So it was sort of a recombinant event, but she definitely had a new, or at least not easily classifiable virus, and that's probably what she presented the scape or the immune scape in her case. So conclusion, well-documented cases of breakthrough symptomatic infections in 2 fully vaccinated subjects, one of them with a very high antibody level. Interestingly enough, the infection occurred with patients with this significant mutation. And finally, it also opens the possibility of recombination. So this patient had sort of an in-between strain that has some similarity to the UK, the V117, and also some mutation of the 526. So they're postulating that maybe there was a recombination and she was infected with a recombinant virus. So interesting. I think they need to elaborate more on this, but it was a lot of interesting. And this article actually made me look for the CDC data on breakthrough infections, and this is what has been reported, and it's in the I think I checked it Saturday afternoon in the webpage. So 7,157 breakthrough infections, and these are infections after 14 days after the second dose of the vaccines among 87 million people. This is the number of patients that were fully vaccinated when they did this analysis. And you can see that, some of these infections were severe. 498 were hospitalized, and actually 88 died. So although the vaccine is extremely protective, it's not obviously 100%. And some of these patients were hospitalized for other reasons, and some of the fatal cases were also for other reasons not related to COVID. But nevertheless, there were some death and some hospitalization directly linked to COVID. The good thing is that if you divide 7,157 by 87 million, you get this percentage. So actually the percentage of getting COVID after vaccination, it's pretty low. It's less than, you're protected 99.992%. So very high degree of protection. But nevertheless, there were some cases, obviously, among 87. So I thought it was interesting. And finally, two quick I'm almost done. Two quick articles, I'm sorry. So this is one question. I'm 20 years old. I'm a college student, healthy. I had COVID a few months ago. Can I get it again? Well, the Marines did a study, very interesting. They had new Marines recruit around 3,000, most of them male, 18 to 28. And before they started their training, they actually did a pretty comprehensive study to make sure that they didn't have COVID or they had COVID. And they found 189 of those recruits had already had COVID in the past. And we're talking 18 to 20-year-old, healthy, mostly males. And then they follow them every couple of weeks. They did a PCR at week 2, 4, and 16 during their training. And they actually had an outbreak. They had an outbreak in this group of Marines. Despite all the precautions, they had an outbreak. And in fact, what they found is that out of the 189 seropositive, those who had COVID before, 10% became reinfected. So 10% out of these 189 seropositive, which give you an incidence of 1.1 case per person year. But the outbreak was huge. Among the seronegative, they found 48. So half of the seronegative became infected in this significant outbreak among the Marines recruits. So you can say, it was 5 times less the risk of being infected if you were seropositive, but it was not 0. It was actually 10% incidence. So very, very interesting, well conducted epidemiological study demonstrating that, yeah, you're protected if you have COVID, but you're not 100% protected. It's more like 80 to 90% protection from natural infection. That's another reason to get the vaccine, to try to improve the antibody levels. And finally, there was a small letter in the JAMA Internal Medicine. That CDC recommended a few weeks ago the use of double mask. So these researchers actually had a device that measured the particles on people, on volunteers with 1 or 2 masks, and they actually analyzed procedure masks, different brands of procedure masks, single mask, double mask, and you can see the level of filtration. They use a calculation called fitted filtration efficiency, which basically counts the number of particles behind the mask. So this is evaluating how mask protects you, not how you protect others with the mask, but how are you protected when you use single or double mask. And there was an increase, obviously, of the protection if you wear 2 procedures, so one on top of the other, and probably more practical and more real. They also analyze cloth masks, either using the procedure mask over or under the cloth or the bandana or a polyester gaiter, and they basically found that in all cases the protection increased significantly from the polyester or the cotton with the procedure below goes from 44, for instance, to 66, and here for 41 to 81. So sort of demonstrating that in fact using a procedure mask underneath a cloth mask increases the protection significantly. So this goes along with what the CDC recommended, and I thought it was interesting to see this at least in an experiment or a real life. And they usually use volunteers. They use a female volunteer and 2 male volunteers to measure these values. All right, thank you. That's it. I took a little bit longer, but it was a couple of good pages.
Excellent. Thank you, Nestor, so much. Really appreciate it as always. Wanted to introduce Dr. Leslie Hayes from Española, our primary care and addiction physician. Dr. Hayes.
Hi, Leslie Hayes. Hang on just a second. And I was really happy to hear Nestor say that it took him a while to understand his study, because one of the studies I'm doing today I found very confusing. But it was so interesting, I did want to cover it. So I'm only going to cover 2. The first is just one that was really big in the news this week. And so I wanted to actually look at the study. And it was on COVID transmission. And it was actually a study by, I don't know if they were physicists or mathematicians, but they were looking basically at air transmission inside and how aerosols would be transmitted. Modes of transmission, large droplet, and the 6-foot rule obviously matters with large droplet, contact, and airborne. So their paper was looking at airborne, when you've got the tiny little droplets circulating, how much is that going to affect transmission indoors? So they're thinking, and they just said a good percentage, and I don't actually know what percentage we really think is airborne versus droplet. I know that we're thinking contact is probably pretty low. And so what they did is they looked at a theoretical model of airborne transmission. If somebody coughed or breathed in a room, what are going to happen to those small aerosol droplets in the room? And where are they going to go? And so they were talking about when people cough, sneeze, sing, breathe, they expel an array of liquid droplets. Some of these are big, some of these are small. These can represent a substantial vector of disease transmission. And so I thought this was kind of interesting. They look at the different levels of virus produced depending on what you do. And singing is clearly by far and away the most. I am not going to be in a room with somebody singing until this pandemic is over. Loud speech is also fairly significant. And all I could think of was the number of people who I'm in a store and they see a friend and they pull off their mask and, hey, Jim, but they're going to spew a lot more viral particles. Speech that's sort of intermediate or whispered will produce less. And then just breathing will produce some, and depending on how hard you're breathing. So, and then they used a lot of math, and this is actually not all of their variables. I just wanted to show you how many variables they had. And I like math a lot. I could not follow their equations. It was too complicated. But using all of this math that they did that I'm just going to have to trust is correct, because like I said, it was beyond my skills. What they found is if you are in an indoor space, the droplet particles are evenly dispersed throughout any indoor space. So it doesn't matter if, when we're talking the airborne, the aerosols, it doesn't matter where you are in the room. If you're 60 feet away from somebody, it's still going to be dispersed so evenly that you're going to be just as exposed if you were 6 feet away from them. And so what they actually found using this was that the most important variables for transmission were cumulative exposure time and whether or not people are wearing a mask, and also the kind of ventilation you had for the room. So this is kind of an interesting thing. I want to go over it in a little bit of detail. So the red line is where it becomes unsafe how long it takes to become unsafe. If you have somebody come into the room, and all the way over to the left, you have the occupancy limit. So we're going to look at 20 people. If you have 20 people in the room and you have natural ventilation, somebody comes in. If you're wearing a mask, I want you to notice, especially the time in masks is in days, the time without masks is in hours, to give you a difference of how much the mask makes a difference. So you have somebody come into the room with COVID, not wearing a mask, and natural ventilation. It's going to take about an hour before somebody else in the room is likely to become infected. If you only have 10 people in, it's going to take maybe 2 hours, but not a huge amount of difference. If you have mechanical ventilation, an air filtration system, it's probably going to take close to 7 hours. Now, if you have masks on and mechanical ventilation, somebody comes in, even if you have 20 people in the room, it's probably going to take 3.5 days before somebody is going to get infected. So there's the 3 important variables: whether or not they're wearing a mask, how many people are in the room, and the kind of ventilation you have. And it really doesn't matter in the room that people are sitting 6 feet apart or 60 feet apart if you've got these aerosols, because they're going to be spread throughout so evenly. Now, in the nursing home, you'll notice you get far less time, and that's partly because they had a much lower risk ratio for the nursing home. They were far less willing to accept somebody being exposed. So with natural ventilation, it's very, very little time that people end up becoming an unsafe risk of infection. And even with air filters, it only goes up to about 24 hours. So very important to wear masks. And it did convince me of the value of the mechanical ventilation or the filters. So take home messages: wear your mask, limit your cumulative indoor time, especially if there's a lot of other people around. Don't count on staying more than 6 feet apart to protect you. Good ventilation of indoor spaces is essential, and don't sing indoors. And the second study was so much easier to understand. I like medical studies so much better. So this was an outbreak in a nursing home in Kentucky, and they had vaccinated the majority of their workers and the majority of the residents. And there was when COVID came into the facility, and it was a newly introduced variant to the region. What they found was unvaccinated residents had a 3 times greater risk of getting COVID, and unvaccinated healthcare personnel had a 4.1 times greater risk of infection as the vaccinated residents and healthcare providers did. So the vaccine was 86.5% protective against symptomatic illnesses among residents and 87% protective among healthcare providers. And so the SNF had done vaccine clinics January 10th, January 31st, and February 21st. There were 83 residents and 116 healthcare personnel. And 90% of the residents got the vaccine, and 52% of the healthcare personnel got the vaccine. I was kind of horrified it was only 50%, but I guess they said that's actually way better than the national for nursing homes, which is at 37%. And they had routine healthcare personnel antigen testing. And 8 days after the 3rd vaccination clinic, and this just made me want to weep, the index case was an unvaccinated symptomatic healthcare provider or personnel who had come into the facility. Once the outbreak was identified, they started doing daily point of care antigen testing of all residents and twice weekly healthcare personnel testing. And they had 46 COVID-19 cases were identified. There were cases in 26 residents, 18 of whom were fully vaccinated, and 20 healthcare providers, of whom 4 were vaccinated. 2 cases occurred in residents who had gotten their 2nd vaccine within 14 days, so they didn't include them in the final analysis. And so, again, they found that vaccinated residents and healthcare personnel were less likely to be infected than unvaccinated person. The attack rate in unvaccinated residents was 75%, whereas in vaccinated residents, it was 25%. Unvaccinated healthcare personnel were 4 times as likely to get it. An unvaccinated healthcare personnel was 29.6% chance of getting it, and an vaccinated healthcare personnel was 7%. And the vaccine efficacy was estimated to be 66% among residents and 75.9% among the healthcare personnel. And if any of your colleagues who are healthcare workers are still hesitant on getting the vaccine, I would point out this study. This one person who came in was responsible for 46 COVID cases, including 3 deaths. So, and that's all I had.
Thank you, Dr. Hayes. That was fantastic. We really appreciate it, and want to move on to Marla Sievers. I think Marla does not have a presentation, but I'd like to introduce Marla Sievers, our New Mexico Department of Health epidemiologist. Marla.
Hi, good afternoon, everyone. I don't have slides or a formal update today, but just wanted to share that New Mexico will be resuming the J&J vaccine distribution this week, following the recommendation from CDC and FDA and ACIP. And there is a clinician call being hosted by CDC tomorrow. I'll put the link in the chat that one of the chair people from the ACIP committee is going to be on, reviewing the evidence and the updated vaccine recommendations. So I think it will be very helpful maybe for clinicians to review that evidence. I saw a preview of it on Saturday at an IDSA call, and it's very good in terms of understanding everything that they looked at, the AstraZeneca data that they looked at, and how they came to their conclusion, basically using a population health lens, which they acknowledged is, a little different than looking at risk benefit for individual patients. So it was just helpful to hear their reasoning and walk through that, and maybe helpful for people as you have questions from your patients about which vaccine they should choose if they have a choice.
Thank you, Marla, so much. Really appreciate that. Want to introduce Carissa Culbreth, the medical director for Tricord Lab. Carissa.
Hi, sorry, it took me a minute to get off of mute. Hello, everyone. Good to see you all today. Next week, I'm going to provide an update on some of the other respiratory viruses that are beginning to circulate now that people are a little bit more out and about, and to show everyone in the New Mexico area where they can access that information from the Tricord website. So I'll be providing that update next week.
Thank you so much, Dr. Culbreth. And now I'm going to turn it over to Dr. Thornton for questions and answers. Thank you, everybody.
Thanks, Joanna. I'm going to go sort of back up to the beginning. That's from some of the studies that you presented. And I don't know, Sarah, do you want to unmute yourself and introduce yourself and just ask your question? Hi, Sarah, go ahead.
I got it. Sorry, for some reason it wouldn't unmute. So my question, Nestor, is my daughter who's at the University of Washington has a roommate who got the Mrna vaccine and apparently had a clot each time. And I've forgotten, one of them was, they were in her extremities. They were not like splanchnic or headache. Now I don't know anything about how this was diagnosed, but that was the party line. So I guess my question is other vaccines besides J&J have been associated with clots? Have they?
Yeah, great question. Yeah, I think there have been reports of DVT and PE, but not with thrombocytopenia and not the typical presentation. So yes, there have been association. Even in the studies, in the original studies, there were a few of those events. But I don't know if they're clearly being associated with the vaccine, and definitely not with the phenomenon of thrombocytopenia and platelet consumption, which is what characterizes the Johnson & Johnson and AstraZeneca clotting disorder.
So there's clots plus low platelets and clots.
Exactly. Yeah, in general, inflammation from any reason, natural infection or vaccination, in theory, can trigger an increase in the or procoagulant state. And also people who use birth control pills, and as you know, other risk factors can have thrombosis, even if they are or are not vaccinated. So that's a reality. But definitely this combination of low platelets and also anti-PF4 antibodies with thrombosis in the splanchnic and other, cavernous sinus and other venous area, it's what characterizes these adenovirus vaccine reactions. And they have not been described, to my knowledge, with those characteristics with the mRNA vaccines.
Esther,
Great, thank you.
if there was a need to get a booster vaccine, would you recommend that this young woman go with a different vaccine, or would you feel okay recommending she get a booster?
Yeah, that's a good question. I mean, did she have any risk factors, I mean, was like, something that predisposed her to the clot. That's what I would try to find out, if it's really associated with the inflammation of the vaccine versus maybe she had a long travel. She drove for 6 hours from one city to the other and then developed a DVT. That would be most likely than the vaccine itself. So I don't know, honestly. I would have to go case by case and see if it's worth taking the risk of giving her the booster or not, depending on the all the aspects around the event and how severe it was, etc.
Great, thank you so much. Harry Seibold is mentioning that he says as more of our population is vaccinated, the risk-benefit analysis that the CDC made would change, correct? Will the FDA and/or J&J reevaluate the risk analysis as things progress?
Yeah, that's a good observation. Yeah, if there are no risk of COVID at some point, yeah, the issue of the thrombosis may be, that's a very a good observation. It may be more of a concern if you're especially in the post pandemic era. People will probably select the safest vaccine as opposed to the one that's going to get you out of the pandemic. So I think that's something. Yeah, I think it's going to evolve over time. But absolutely interesting comment. Yeah.
Yeah, thank you. Marla, I don't know if you had any comment about that.
Yeah, I also thought it was a great point. And again, in the CDC analysis, they really did look at incidence rate of disease, as Nestor covered, and sort of making this risk benefit calculation. So, as the pandemic winds down and we have less, fewer cases, then that may obviously change. And if we learn more about what the underlying risk factors are for people who develop this complication, we expect then we see changes to the vaccine guidance, but I think we just don't have enough to go on right now.
Thank you, Marla. I don't know, Ellen, are you able to unmute? Oh, there you are. I see you in front of me. Do you want to just talk really briefly about your patient?
Sure. It's Aline, by the way, just for future
Aline,
reference.
Okay. Thank you.
Yes, so this is a lady that does tend to have inflammation in general. She has a head injury, among other things, that has caused that. So she had a really pretty extreme reaction to the Mrna vaccine. Both shots, really very severely swollen arm, itching and pain, lots and lots of redness. So she told me earlier today that, and showed me that she had developed a rash like in the collarbone area. And this may have nothing to do with the vaccine, but it was 3 weeks after her second shot. And she just wondered if anyone's been seeing skin inflammations that long after the vaccine, if this is a known issue and if it could possibly be related. I hadn't heard anything about anything.
Nestor, go ahead.
Yeah, I'm trying to remember. There was a paper in the New England that I discussed here about skin complications of vaccination, and they were actually delayed like 8 days. So it's probably within the range. And I saw photos of lesions in the elbows, not exactly in the collarbone, but actually distal. I mean, distant from the injection site. So it's possible. It is possible that this is a delay, hypersensitivity reaction, something we see with like the fixed drug eruption that can occur anywhere in the body. So it's possible, because I remember there were, I think, 12 cases with the photos in the New England Journal, and some of them occurred a few days after the vaccination. They were mostly with the first dose, because that's what they published, the first dose, and then they gave a second dose to some of these patients. But some of the lesions were away from the injection site, because I remember the photos of elbows and other areas of the body. So it's possible.
Thank you, Nestor. Marla, did you have any comment? I saw that you were shaking your head.
Yeah, I just was thinking back to the study that Nestor covered, and I think the range of symptom onset was 4 to 11 days, with intermediate being 8 days. So yeah, up to a couple of weeks out, this definitely was observed. I haven't seen any literature that talks about these delayed skin reactions beyond sort of that 2-week period. But certainly anecdotally, I've read a few things about it and heard that people have reported those.
Thank you. Thank you. Dan Saltman asked an interesting question, Nestor, about the VA study. Are there similar studies of excess burden of disease post-infection from infection with other viruses like influenza?
In fact, they actually compare, they look at the data from influenza in the BA and they compare post-influenza and post-COVID, and indefinitely post-COVID was much worse in all sense. I mean, there was more resources utilization and everything. Of course, there's some after influenza, especially heart failure and pneumonias that we see, but this broad array of things happening to the patients post-COVID was not described with influenza, and they actually compared. They did a small part of their study that I didn't even comment on that, but they did compare post-influenza with post-COVID, and it was definitely much worse with COVID. But yeah, that's a great question, but it's not even close. It was really worse with COVID.
Great, thank you. And then Deborah Hill is asking, do we have any news to report on any vaccine studies in children under age 16? Anybody heard anything? Marla, have you heard?
Yeah, nothing new. I talked a couple of weeks ago about the fact that Pfizer had requested a modification to their EUA from FDA to be able to vaccinate children down to age 12. I thought we might have heard something from FDA about that request, so I'm a little surprised we haven't, but it may have sort of been put on the back burner with the questions around J&J. But I know that Mrna has started their pediatric trials as well and released some preliminary data, and are expected to request a modification to their EUA. Sometime this spring was the time frame that they mentioned. So I think we'll be seeing more about that soon.
Carla, could I ask a follow-up to Marla about that? I'm just wondering with schools across the country, now opening up, and especially in New Mexico, I'm wondering, it seems that there's more of an urgency to get, the 12 to 16-year-old group vaccinated, and even the younger group, and also wanted to see how things are going in New Mexico with cases in kids now that schools are open.
Yeah, I agree. I think, hopefully the goal is that by fall, when schools reopen, we have at least some of our kids vaccinated. If we were able to vaccinate middle school and high school populations, I think that would go a long way to reopening schools fully and people feeling safe about sending their kids back to school. We haven't seen a big bump in cases, with the limited school reopening we've had so far, but we are definitely monitoring that, though some schools are really still sort of standing up their testing strategies, but we haven't seen a marked increase in cases at this point.
Great, thank you. Harry Seibold, are you on? I can't see you on my screen.
I'm here.
There you are. Yeah, do you want to go ahead? You want to ask your question about the study in pregnant women?
Sure. When you read what Dr. Sosa posted, Dr. Shimabukuro, there was a term, no obvious safety signal. I've never heard it worded that way. Is that the same thing as saying statistically there was no increase in adverse events to pregnant patients, or was it meaning that it's just a gestalt rough look at things that we didn't see anything obvious? I just wasn't sure how to interpret that terminology.
Yeah, me neither. I mean, I think that the fact that they're just comparing what they have seen with the Be Safe reporting system and the published literature is sort of a, not a very robust analysis in that way. They're not doing a comparison of vaccinated versus unvaccinated. It's actually, comparing what has occurred with this patient with what has been published in the literature. So I think that's where they're sort of careful with the wording, saying there's no obvious safety, because they're not like following this patient longitudinally. This is not a prospective study. This is not a comparative study of vaccinated pregnant versus unvaccinated pregnant, etc. So I think it's that they didn't see any like red flags comparing what occurred to them with what it's normally occurring in the society or to other populations in the same condition.
Yeah, thank you. I don't know if you were going to say anything about this. Eva Angeli is asking about if you were going to talk at all about the situation in India, and what do we know about if there are variants there, or it's just what your knowledge is.
No, I'm sorry, Eva, I haven't really heard anything. I know the situation is horrible. I was listening to the BBC radio when I was coming into the hospital today, and they're describing, you know, a really desperate situation with lack of oxygen, lack of beds, especially in New Delhi and other large cities. But I don't know. I don't understand what's happening, if it's you know, maybe a new variant circulating or something else. I remember that at the beginning, in March last year, March, April, I was worried that Brazil and India, which are you know, highly populated areas, were going to be the hotspots, and it turned out to be the U.S. and some other places in Europe. Too much to my surprise, and now sort of the virus is catching up with that reality. The fact that these are, you know, large countries with a lot of poverty, a lot of health issues, and social determinants of health in general. But I don't know about the variants in India and what's going on with that.
Thank you. Did anyone else on the Hub team have a comment about that? No, okay. There's a question about, I don't know, Minister, do you have any, what is known about the vaccines from the Republic of China, or any clinical studies that you've seen, anything, any reports?
Yeah, I've seen 2 publications out of South America, Brazil, with the CoronaVac, and their efficacy or effectiveness, because these were real life studies, because I haven't seen a clinical study with especially with the CoronaVac, which is the one that I use in Latin America. It's around 50 to 60% efficacy. That's what they have published. Both Chile and Brazil have published. This is real life effectiveness in the midst of a pandemic. So with all the limitation that those publication entails, it's so around 60% efficacy, which is not dissimilar to what have been seen with AstraZeneca in South Africa or in other places. So yeah.
Thank you. I just wanted to let everybody know that the CME link went into the chat at about 12:44. Please give us your feedback, and if you want to like CME, please fill that out. And I'll turn it back over to Joanna.
Thanks, Carla. Jeffrey Miller has a question, Nestor, Leslie, about wondering about the pathophysiology that from patients who've had COVID that results in increased diabetes or hyperlipidemia. Wondered if you kind of know about that or have read about what might be causing that, if it's an inflammatory process or.
Yeah, Leslie, you want to say something?
I know in general, any sort of physical stress increases level of stress hormones, which tends to make people more insulin resistant. And so it seems to make sense that since COVID is such an incredible physical stress, all those circulating hormones are going to make people more insulin resistant and more likely to develop diabetes. But I haven't read any direct, you know, this is causing this, that causes this. So.
I think Dan Saltman, do you want to unmute? I think you responded a little bit to Jeff Miller's question.
I saw a piece that was about oh, thank you. I'm sorry, I just unmuted and jumped in. But
That's
thank you.
fine.
Thank you, Joanna. I saw a piece that was about the impact of the gut biogenome on COVID infection. It was sort of a specific thing. And the proposal was that maybe that goes some distance in explaining why obesity and diabetes are higher risk for complications. So I was wondering if you had any thoughts on that.
No, I do not. I haven't really read that article, and I agree with Leslie. And I think there are 2 phenomena here. One is the inflammation and the fact that the patient have an acute stressor. Some of the patients also, especially the relatively young, the 40, the 50-year-old, who were diabetic and didn't know they were diabetic. Because I remember when we saw the patients in the hospital, a lot of them said, no, I never checked my sugar before, or I didn't know I was diabetic, and they turned out to have 180, 160. So not like a horrible diabetes, but they were, some glucose intolerance, and this hospitalization basically detected that because we have to do all the blood tests. So I think those 2 factors are playing. The third factor is it's sort of more concerning. Do the virus invade the pancreas? And I have seen papers talking about the beta cells having the ACE receptor and the TMP, the enzyme that actually activates the virus to There is this theoretical possibility that some diabetes may be because of direct attack of the virus to the pancreas, but obviously it's all like hypothetical. So all of those are possible hypotheses for this link. And obviously the microbiome is an interesting one. I haven't read about that, but I guess it's also possible. So I think we need more information to be able to, and probably it's going to be all of the above. There's going to be some patients who actually have like a direct autoimmune attack into the pancreas, other virus attack into the pancreas, and other are just decompensating their undiagnosed but pre-existing diabetes. You know, the hospitalization and the dexamethasone that we're giving them also helping in that regard.
Then the one other thing is that for type 1 diabetes, I think the theory is that all viruses, but in particular COVID, can cause autoantibodies that destroy the pancreas. So
thanks for that great mini discussion. That was awesome. I think related, Dr. Hayes, to one of your studies, Dr. Seibold kind of is interested in, you know, that one patient that infected kind of created 46 other cases that you talked about. He's wondering about contact tracing. What was the calculated R0, and what perhaps was the variant there? Do you remember about that case?
Yeah, I know they said it was not a named variant. It was definitely a variant that was new to Kentucky, but it didn't sound like it was a variant with a name or a specific one. And they did not calculate R0 in that. And the contact tracing they did that they talked about in the paper was limited to the nursing home, which they did by instituting the daily testing for all residents and twice weekly for all healthcare personnel. Right. I think they may have actually bumped it up to daily for the healthcare personnel. And they did mention they were using the rapid antigen test. And they said they probably did miss some cases because of the fact that that is less sensitive than the PCR. So
that really was a super spreader. Yeah, I was watching the Academy Awards last night, and I was wondering, kind of, did people who attended have to give a vaccine, a vaccine card, or how did they, why was the guy who runs the academy, why was he so positive that it was such a safe environment? I was wondering all those questions as I was having fun watching the Academy Awards. But anyway.
Well, my daughter is a big fan of the TV show The Bachelor and The Bachelorette, and they require everybody to go into 14 days of quarantine and be tested before they can actually be on the show, which I wouldn't want to be on The Bachelor anyway, but especially the idea of having to go into quarantine for 14 days beforehand.
I do not think they did that for the Academy Awards last night, for sure. Yeah, interesting. They really wanted to showcase that you do not need to wear masks indoors. That was a very big goal of theirs. It'll be interesting. Nestor, do you have any thoughts on that
in the defense of the Academy, which I never thought I was going to defend the Academy, they changed the venue from the usual theater that they do it to this area, which is bigger, etc. And they were able to space the tables. That's what they said in their defense.
Yeah.
So it was not like the usual
right.
Packed theater, everybody seating, everybody hugging and kissing each other. They actually have some rules, and one of the rules was they changed the venue into like a sort of a hangar type of area, bigger area, more dispersion.
No drinks.
Yeah, yeah, exactly. Yeah. So they did some efforts to decrease the risk.
It was very interesting to watch.
Yeah. Interestingly enough, Anthony Hopkins 83 didn't show up, just in case.
Yeah. Kim Joy has a question for anybody, and Carissa, I think in particular. She wants to know the accuracy of the home over-the-counter antigen tests, I think called Binax now. Carissa, are you on?
Sure, yeah. So the Binax test that's being sold over the counter, it's the exact same as the Binax test that's used in drive-through locations, maybe the one that was used at the nursing homes that Leslie was just mentioning. And so we've seen local studies as well as studies that other groups have done, that even in symptomatic patients, the sensitivity is probably in the low to mid 80s at best. In asymptomatic patients, the sensitivity is even less. And that was when the test was performed by either trained laboratory personnel or trained clinicians who'd received some type of formal training in getting the test done. The challenge is now with the test being provided over the counter, there's just a instructions, and for anybody who's done any kind of over-the-counter test, that can be a little bit confusing. I haven't bought one yet myself, but other colleagues have, and they've said it is, a little cumbersome and maybe a little bit difficult to figure out how to do that testing. So we do have some concern, I think, about just the overall performance of the test in the hands of the routine user. So I don't know that we have data in its over-the-counter form, but we do have data in its standard form. And I think somebody else also asked about specificity. The test itself has good analytical specificity, but remember, even a test at 95% analytical specificity, if it's in a low prevalent setting, you still have a higher risk of having a false positive than a true positive when you just go back to the basic math around sensitivity, specificity, and prevalence. So keeping that test focused on symptomatic people is definitely an important thing for us to consider.
Thanks, Dr. Culbreth. How much is the over-the-counter? How much is the test?
I think it was $27 for 2 tests. There's a kit. It has each of the kits has 2 tests in it, and it's $27.
Great, thank you, thank you. Dr. Ben Dates and Dr. Julie Broyles kind of both are interested in an issue that maybe Marla or Nestor might want to help answer. They are asking if the present emergency youth authorizations are lifted, and we're still considering that many Americans are kind of unvaccinated and might want to remain unvaccinated. Is there discussion about mandating vaccination for healthcare workers, students, et cetera? And I'm guessing, different employers. Nestor or Marla, do you want to take a stab at that?
Sure, I can start. There's definitely a lot of conversation about this, obviously, especially as it's approved, hopefully, for children. Does this, and depending on the trajectory of the pandemic, does this become part of your routine childhood vaccine recommendations? Right now, most of the vaccine mandates, like if you look at influenza vaccine requirements, are really employer-based or specific policies of educational institutions rather than, a Department of Health policy or a national policy, and I think probably that's where we'll see the vaccine mandates first, and we're already seeing that in some universities, is that, private groups and employers are going to be the first to come out with these requirements, just like they do with the annual influenza vaccine. I think it'll be probably a while until we have full FDA approval, ACIP makes some recommendations, until we would see this maybe rolled into a state level vaccine requirement. So I think we're probably, quite a ways out from seeing something like that happen if it does.
Thank you, Marla. I definitely know several private universities are saying in the fall students are going to need to bring their vaccinations, one of them being New York University, and others are gearing up towards that, I think. Any other thoughts, Nestor or Carla, Carissa, on that?
No, my son's school, go ahead. My son's school required everybody to sign that they would get the COVID vaccine when it came out, and they are in the process of vaccinating the entire student body. They've had, I think 60% have gotten at least one, and 20% are fully vaccinated, so.
Thanks, Leslie. Nestor?
No, I have no comment. I mean, I just can say, that there are some precedents, obviously. Like I can give you the in Latin America, we are obligated to have yellow fever vaccine if you go to certain countries, mostly to travel. So that's something that, so travel mandated vaccines have been there for forever. So I don't know if there's going to be the place where they're going to mandate. Maybe some countries will do that. Well, if you want to go do tourism or do something in a country, you need to show proof of vaccination somehow. But I honestly don't know what's going to, because there have been so many politicized aspects of this pandemic that I don't want to really predict what's going to happen with the vaccination.
Right. Well, everyone, we're at the top of the hour. Thank you so much. I wanted to let you know we continue to have many other ECHO programs, including the First Responder ECHO at 2 o'clock today. We have a great speaker from Silver Hill Hospital, a physician, Dr. Andrew Gerber, talking about residential treatment for patients with substance use and mental health issues, and many patients who are having a difficult time regarding COVID-19 or benefiting from residential treatment. And he'll be talking about mental health resiliency. And then on May 6th, the Critical Care ECHO will be focused on COVID-19, I believe, vaccine clots and how to manage them with Michelle Harkins. And then on this Thursday, we have our mental health and resiliency ECHO with the IHS. And I think that's it. Carla, do you have any last minute announcements?
No, I think that on the May 6th, it's going to be about anticoagulation in the hospitalized setting.
Oh, okay. Okay, excuse me. And thank you. I think that's it, and we'll see you next week. And Carissa has a presentation for us that we'll look forward to. Thank you, everybody.